think we should start now, right? We have Dr. Jina here, Dr. Anita is already here, Dr. Bosudha is already here, Dr. Sherwaz is also here, Dr. Deepak is here. So today we'll be starting again about the prescribing guidelines and IPC for microbial stewardship. I think Linda will join after some time. We can wait for her, but we can continue. Is it okay, Dr. Marcus? Can we start?
Oh, yes, please. So you met Dr. Gina Mackey, who's infectious disease with us, and now Anita Shalalas, another one of our infectious disease doctors that will be doing the presentation together with us three together.
So I'll give this mic to our Mr. Badachari Deepak ji. Hello, Deepak ji.
Thank you, Dr. Saab. So we'd like to request Anita Salal and Gina with infectious disease. So please go ahead for your presentation. Talk program.
Sure, thank
Anita.
you.
Yeah.
Okay, thank you. So obviously I'm going to be talking about the guidelines for antimicrobial stewardship, and we're representing Henry Ford in Detroit. So just a quick outline of what we're going to talk about today. We'll start with kind of a basic overview about antimicrobial stewardship. Then we'll get into some empiric antibiotic therapy and then some stewardship tips. We'll talk a little bit about duration of therapy, tips for prophylaxis, how to transition to oral therapy and when, and renal dosing. So what is a guideline? These are created as statements and recommendations with the intent to guide decisions in order to optimize patient care. And really, these are going to be based on review of evidence. And they're intended to fit the majority of patients. But as physicians, we should always individualize each patient when we're addressing therapy. The purpose of the guidelines are going to be to improve patient outcome and quality of care, reduce inappropriate variation on practice, encourage proven treatments, educate providers, and improve efficiency of healthcare. So moving right along into empiric antibiotic therapy, you're going to use these when culture results are not available. And this is going to be based on the site of infection and the organism or bacteria that's most likely to colonize that site. And again, you're probably going to hear me say this a couple times, but individualize it. So you also have to look at prior knowledge of bacteria that is known to colonize the patient and the likelihood of drug resistance. And then you're going to use local bacterial resistance patterns and antibiograms that are available in your hospitals. And then you're going to want to de-escalate. So you should change antibiotics when you have new data in front of you. And then look to de-escalate from a broad spectrum antibiotic to a narrow spectrum antibiotic. Take away anything that's unnecessary in the antibiotic regimen once you have more data, and discontinue antibiotics when you decide the patient doesn't appear to have infection. And convert IV to PO when possible. Duration of therapy. There's a lot of problems with giving patients prolonged courses of antibiotics, whether it's adverse reactions from the antibiotics. Patients can have adherence issues when they leave the hospital. You can select out for resistant organisms, and of course, it's a high cost. So we should always attempt to use the shortest effective duration. And again, individualize the duration based on your clinical, laboratory, and radiologic findings and the patient response to treatment. And colonization. So we do not treat colonization. Colonization is kind of defined as a positive culture in the absence of infectious symptoms. So for example, a patient who has no symptoms of a urinary tract infection, but urinalysis shows white cells in the urine or bacteria, this is colonization and should not be treated. Common populations for colonization: indwelling urinary catheters, endotracheal tubes in mechanically ventilated patients, and chronic wounds can become colonized as well. Okay, so now we're going to talk a little bit about empiric antibiotic therapy. So community-acquired intra-abdominal infection. So on the left side of your screen, you'll see the suspected pathogens. So you're going to want to direct your therapy at those organisms. And then in the middle of the screen is going to be kind of your empiric options. And to the right are just kind of some additional notes. So for an intra-abdominal infection, you want to cover for Enterobacteriaceae, Bacteroides, Enterococci, Streptococci. So your preferred empiric therapy is going to be ceftriaxone and Flagyl, plus or minus gentamicin. Alternatively, you could use piperacillin, tazobactam, cefepime and Flagyl, imipenem. And then oral options for outpatient therapy would be ofloxacin and Flagyl or moxifloxacin. So when we're talking about these kinds of infections, I guess what I'm referring to is kind of cholangitis, cholecystitis, diverticulitis, intra-abdominal abscess. Please note, pancreatitis without necrosis does not require antibiotics. And adding gentamicin is appropriate if you suspect a multi-drug resistant organism. Moving on to inpatient treatment of COPD exacerbations. So your suspected pathogens are going to be H. flu, strep pneumo, and Moraxella catarrhalis. And your empiric therapy options, your preferred option is going to be azithromycin. You can also use doxycycline. You should only use antibiotics if there is increased sputum volume and or purulence, or if they have acute respiratory failure requiring ICU admission. Moving on to enteric fever. So your suspected pathogens here are going to be Salmonella. Empiric therapy is ceftriaxone or azithromycin, and you're going to treat for 5 to 10 days. Gastroenteritis. So you're going to want to cover for Salmonella, Shigella, Campylobacter. Preferred therapy here is ciprofloxacin, ofloxacin. You can also use Bactrim, alternatively azithromycin. And Salmonella and Campylobacter, treat if it's a protracted course or if they have comorbidities, and Shigella should always be treated. Meningitis, so your suspected pathogens here are going to be strep pneumo and Neisseria meningitidis and Listeria. Empiric therapy is going to be ceftriaxone plus vancomycin or linezolid, and then plus or minus ampicillin to cover for Listeria if risk factors for Listeria are present. So risk factors are listed here in the notes: alcohol use, age over 50, and pregnancy. And TB, meningitis, you should use, of course, anti-tuberculosis medicines. Pneumonia for inpatient treatment, community-acquired pneumonia. You want to cover for strep pneumo, H. flu, mycoplasma, chlamydophila, and Legionella. So your empiric therapy here is ceftriaxone plus azithromycin or ceftriaxone plus doxycycline. Amoxiclav and moxifloxacin are some options for oral therapy. And your recommended duration of treatment is 5 days, but we'll get into duration in a couple slides. And then community-acquired outpatient, same organisms, and the empiric therapy is going to be azithromycin. For patients with comorbidities, you should consider a fluoroquinolone, such as moxifloxacin or ofloxacin. And then amoxicillin and azithromycin or amoxiclav are other options. And then for patients with risk factors for multi-drug resistant organisms with pneumonia, so if they have risk factors for hospital-acquired pneumonia or ventilator-associated pneumonia, that's where you want to cover for Pseudomonas aeruginosa, Acinetobacter, and some of the Enterobacteriaceae. So your empiric therapy here is cefepime plus or minus vancomycin or linezolid. Piptazo is another good option, plus gentamicin, plus or minus vanco or linezolid. And if you suspect Acinetobacter, you should consider using colistin plus or minus tigecycline. And then add gentamicin or amikacin in patients with severe sepsis or septic shock, just to kind of give you a little bit of double coverage in this case for Pseudomonas. And skin and soft tissues infections such as cellulitis, you're going to cover for staphylococci and streptococci. Preferred oral options are cloxacillin, flucloxacillin, cephalexin, cefadroxil. And then if they don't have a history of MRSA and you don't need to cover for it, then you can use IV therapy in patients that are admitted. So cefazolin is an option as well. Purulent cellulitis or after failure of IV beta-lactam therapy, or if they have MRSA, that's where you're going to use vancomycin or linezolid. And then if there's an abscess, again, suspected pathogens are more typically staphylococci, but also streptococci. And so surgical consultation for drainage is going to be of utmost importance, and empiric therapy can be with cefazolin, amoxiclav, flucloxacillin. And then if failure of IV beta-lactam therapy or MRSA, vancomycin or linezolid. So similar to the last slide. Important to drain though. Skin soft tissue infections that are polymicrobial, such as burns, open wounds, especially in our poorly controlled diabetics. Then you're thinking of staphylococci, streptococci, Enterobacteriaceae. Your empiric therapy is going to be cefepime and Flagyl, plus or minus gentamicin, plus or minus vancomycin, or linezolid. If you suspect Acinetobacter, again, like we talked about on a previous slide, colistin plus or minus tigecycline. Urinary tract infections and uncomplicated cystitis. So this is for uncomplicated infections. So for example, a young female comes in with urinary symptoms, then you're going to want to cover for Enterobacteriaceae. Nitrofurantoin only is your preferred option here, but only if their creatinine clearance is over 40 to 60 or their age is under 65. Ofloxacin is another option. And for pregnant women, can use cefixime. And then urinary tract infections for complicated pyelonephritis, your suspected pathogen. So here, this is a patient that, for example, is septic, or they have flank pain, or they have other risk factors for a complicated UTI. So you're going to cover for Enterobacteriaceae. IV options are preferred in these sick patients, and so you're going to use piptazo, ofloxacin, imipenem, cefepime, and your PO options would be ofloxacin or cefixime for pregnant women. And then this is another situation where you might want to consider adding gentamicin or amikacin in patients with suspected Pseudomonas with severe sepsis or septic shock, and stop after 3 days. Some tips now on stewardship. So that was sort of talking about empiric therapy. So when you start when they come in and they're really not doing well, you start them on the empiric therapy. But then as you get some more information, you really want to try to de-escalate the antibiotics, and that's where kind of our stewardship comes in. So these are some examples of antibiotics on reserve. This group of antibiotics was created by the World Health Organization in 2017. They're recommended to be used as last resort options when alternative options have failed. And the aim is to preserve the effectiveness of these antibiotics. So the antibiotics listed here as trionam, cefepime, daptomycin, polymyxins, including colistin and phosphomycin, linezolid, and tigecycline. So always attempt to get bacterial cultures. That's going to be the thing that gives you the most data to help you de-escalate antibiotics. Stay up to date with your hospital's antibiogram so that when you're doing empiric coverage, you're making sure to cover things that in your community can be covered. Avoid empiric quinolones for most infections because of high resistance rates. Avoid using duplicate antibiotics that cover the same organism unnecessarily. So we see it all the time, even here, when patients are on piptazo, which covers anaerobes, yet they're also on metronidazole. So that's double anaerobic coverage, not necessary. Always de-escalate to the narrowest antibiotic therapy possible when susceptibility results are available. Continue to assess if the patient is truly infected and treat only for the minimum duration necessary to cure the patient from the infection. Utilize oral agents whenever possible to prevent catheter-associated infections. And avoid treating asymptomatic bacteriuria. Definitive antibiotic therapy. Again, de-escalate based on your culture results. Narrow therapy to decrease side effects and reserve your broad spectrum antibiotics. and try to transition IV to PO when possible. So next we'll move on to duration of therapy. Remember, treating infections longer is not always better. So suggested duration of antimicrobial therapy. So beginning with the intra-abdominal infections such as cholecystitis, cholangitis, diverticulitis, duration of therapy, the main thing here is going to be source control, frankly. So with adequate source control, you're going to want maybe 4 days of antibiotics. But if something was ruptured diverticuli, et cetera, then you're going to want source control and about 5 to 7 days of antibiotics. But again, you always want to tailor your antibiotic duration based on your patient as well. Asymptomatic bacteriuria, trick question. It's 0 days. So asymptomatic bacteriuria treatment is harmful for most patients. So you're not going to treat this. So treatment is only indicated in patients who are pregnant or undergoing a urologic procedure. Candidemia, if there's no ocular involvement or other metastatic complications and the patient's not neutropenic, then you're going to treat them for 14 days from the first negative blood culture. If they're neutropenic, then you will treat for 14 days from the first negative blood culture and resolution of neutropenia and symptoms. And then any ocular involvement, you're going to treat for 4 to 6 weeks. COPD exacerbation, the duration of therapy here is going to be 5 days. And according to the GOLD guidelines, you really only need to use antibiotics for COPD when there's increased sputum purulence and increased dyspnea or sputum volume. So antibiotics are also indicated if the patient is mechanically ventilated, of course. Meningitis, that is community acquired. So it actually differs based on the organism. So Neisseria, you're going to treat for 7 days, H-flu, 7 days, strep pneumo, 10 to 14 days, and Listeria, you're going to treat for greater than or equal to 21 days. And then community acquired pneumonia. If there's a prompt clinical response, then you can really treat this for 5 days. But if the clinical response is delayed, then you can go from 7 to 10 days. Please note, patients should be afebrile for at least 48 to 72 hours and have no more than 1 CAP-associated sign of clinical instability before discontinuing antibiotics. Hospital-acquired and ventilator-associated pneumonia. If the empiric therapy was active and there was prompt clinical response, 7 days should be adequate. And skin and soft tissue, so cellulitis infections, if there's a prompt clinical response, 5 to 7 days. If there's a delayed response or if the patient has neutropenic fever, then 7 to 14 days. Uncomplicated cystitis, so again, a young female, normal genitourinary anatomy. You can treat this with 3 days if you're opting for nitrofurantoin, or 3 days of Bactrim, or if you're using a beta-lactam, then 7 days of therapy. Urinary tract infections that are complicated, including patients who are bacteremic with pyelonephritis. You can treat this for 7 days. This is where you could use ceftriaxone for 7 days, urinary quinolone, and then other beta-lactams, you might want to go about 14 days. Prophylaxis pearls. So this just kind of is a chart that kind of summarizes some of the other situations that we haven't really talked about. So chronic wound treatment, empiric therapy, there's really none. Duration of therapy, none. So chronic wounds, the best treatment for these are going to be wound care, frankly. So antibiotics are not indicated. Burn treatment, again, no empiric regimen and no duration of therapy for me to tell you guys about, because again, wound care is going to be of utmost importance. And then preoperatively, if there's an infection suspected, then you can use ceftriaxone for 1 to 3 doses or some other 3rd generation cephalosporin. And postoperative treatment, again, ceftriaxone for 1 to 3 doses. when we want to talk about transitioning to oral therapy. So when is it appropriate to switch a patient from IV to oral? So the following criteria must be met. So patients admitted to so if the patient is now out of the ICU on a general practice unit and has received or at least tolerated 1 dose of the medicine and is tolerating a diet, and they've received the medication for at least 24 hours, and they're afebrile for at least 24 hours with resolving or normalizing white count, unless they're on steroids, which can make their white count abnormal. Patients who you should really kind of reconsider whether they should be switched to oral therapy. These are going to be patients who don't have a functioning GI tract. So do they have gastric obstruction or ileus, persistent nausea and vomiting, strict NPO, whether it's for a procedure or a medical reason, patients receiving treatment for an active GI bleed, neutropenic patients, and then sort of depending on the clinical situation. So patients with meningitis or brain abscess, endocarditis, MRSA bacteremia, these are patients that oral therapy is really not appropriate for. You're going to want to use IV medicines for the best possible chance at a cure. And then feeding tubes that are intestinal access only, for example, J ports, J tube, PEG tubes, or any other feeding tube that's accessing the small bowel. So just some examples here of bioavailability of some of these drugs and how to kind of convert them orally. So azithromycin has about 50% bioavailability. So it actually converts to the identical dose. So if you're giving a 500 milligram IV dose, you can switch them to the 500 milligram PO dose. Clindamycin's pretty bioavailable, about 90%, but please note that the dose IV is a higher dose than the PO dose, but the frequency changes as well. And that's the same in the next statement here. Ciprofloxacin, pretty good bioavailability, but again, the dose changes when you switch it to oral. And then renal dosing. Antibiotic renal dosing. So how are antibiotics usually dosed? So we use the Cockcroft-Gault creatinine clearance equation. So this is going to be 140 minus the patient's age times their weight. And you're going to divide that by 72 times the serum creatinine. And then you're going to take that whole number, and if they're female, multiply it by 0.85. And that will give you the patient's creatinine clearance. If they're male, you don't have to multiply it by 0.85. So just an example of how to use the antibiotic renal dosing. Amoxicillin is sort of our listed one here. So if their creatinine clearance is greater than 30, then the standard regimen is 500 Q8 or 875 Q12. And for community-acquired pneumonia, you're going to want to use a higher dose in combination with a macrolide, such as azithromycin. And then creatinine clearance of 10 to 30, then you're going to kind of have to go down on your dose and your frequency. So the dose would be 500 milligrams every 12 hours. And the dose is a little bit higher for CAP. Under 10, even less frequent, so 500 milligrams every 24 hours. And then patients on dialysis, you should schedule it after dialysis on dialysis days. So just a quick summary. It's important to avoid variance in prescribing. Helps to standardize therapy. Avoids unneeded antibiotic use. And improves patient outcomes. For further resources, this is the website that I believe you guys have all been working very diligently on. Thank you. I'm happy to take any questions myself, Gina and Dr. Zervos as well. And I think Linda's here.
Hi, Linda.
Good evening, Dr. Linda. How are you? Is she here?
Okay, sorry, I was on mute. Good morning and good evening, everyone. Thank you, Anita.
Thank you.
Any comment from Dr. Marcus?
Yes, thank you, Dr. Joshi, and for helping to organize this. Deepak also for and your group for helping to organize this, and Linda and Anita, of course, for Dr. Shalal for the presentation. The antibiotic resistance continues to be an important issue, and our best opportunity for control of antibiotic resistance is by using antibiotics the best we can. And I think the important, there are a lot of important principles around appropriate antibiotic use, and because of COVID, it's become even more challenging now, and deciding what to do. And there are many challenges that include being able to get cultures to de-escalate, and often empiric antibiotics are used or continued because of that. But one of the most important opportunities is to as Anita mentioned, not to treat colonization if it looks like, maybe, it's uncertain when somebody comes in the hospital, but if it looks like after a few days there's no infection, or they don't need antibiotics, there's no reason then to continue antibiotic therapy. Duration of antibiotics is a really important way that we can cut down on unneeded antibiotic use, and there are now pretty good data of good outcomes with short antibiotic therapy for things like community-acquired pneumonia, and for things like intra-abdominal infection, and short antibiotics when the focus is removed. But the challenges, there's still a lot of challenges because of antibiotic resistance, and when to use more broad spectrum antibiotics. But hopefully cultures can be obtained to help guide that therapy. But also, if somebody doesn't respond to antibiotic, would be another concern for when those organisms will be present. But we would be glad to take questions and comments. But I guess I would also thank everybody for not only organizing this, but for the participants for your attention.
Thank you, Marcus. Linda, I think you need to give it talk. I don't know as to what topic.
Well, I'll just echo what Mark said, that in terms of thanking everyone for being here, and thanking GTA for organizing this, and Anita and Gina for putting together this talk. So so we're open for questions now.
Yeah.
One comment, Dr. Linda.
Yes.
Last 3 sessions, we have not seen your face.
It's too early in the
It's so early in the morning.
Okay, next time we'll have program in the morning, and we will have in the evening. That will be better.
If someone has a questions, you can ask in Nepali also, and Dr. Joshi will help for translation. That's what my understanding. So कसैले नेपालीमा पनि सोध्न सक्नुहुन्छ. Dr. Joshi हुनुहुन्छ, Dr. Basudha हुनुहुन्छ, उहाँहरूले सायद ट्रान्सलेसन गर्नुहुन्छ अथवा उहाँले रेस्पोन्स गरिदिनुहुन्छ.
I think.
Hello. Good evening, everyone.
Good evening.
Regarding today's webinar is very nice, very fruitful. But if you could have add and recent advances of our Nepalese context, this antibiotic use guideline, like what she talked, 2 things, it would have been better to understand how people, how physicians, nurses, and doctors practices antibiotic in Nepal.
Dr. Deepak, why not you introduce yourself?
Yeah, I have already been introduced.
Last time.
Myself, Dr. Deepak Yadav, working in the BP Kuala Institute of Health Science in Haran as a public health, consultant or student. And yeah, I'm involving this with whole system. Thank you.
So no, thank you for that. Thank you for that comment. That's a very, very important comment. And the guidelines, of course, they need to be contextual for the, for your own, your own situation and use, and, apply to the, to your setting and the patients that you're treating, and also to the local resistance. What, may be used in a burn hospital, might be different from another hospital. So it's even sometimes hospital specific, and the guidelines are never meant to be like a fixed document. They're always need to be open to change and to modification and to consensus, based on what the what you're doing, what you're doing there and what you think is valuable. So these guidelines were developed with the together with the physicians in Nepal, and Dr. Joshi was very involved in that. But there's always opportunities to to revise them, based on what people are doing there now. So thank you for that comment.
Yeah, very nicely. Actually, what we used before, antibiotic, like for a minor health problem, and this COVID experience with the COVID era is different, very different. So nobody like wondering having chest symptomatic longer period, no. So our use of antibiotic, or you can say like in advanced use of antibiotic, very much like practicing, like prophylaxis. So these are the things like when a normal situation and when is a like a pandemic type of the infectious disease.
No, thank you very much. We would like to work together with you to do that. Oh, Dr. Joshi was going to comment.
Doctor, I just mentioned, like during COVID time, when we are patient all over Nepal, so doctors didn't have the experience also. We know that's a viral infection, but we could not rule out secondary infection, bacterial infection. And patients sometimes deteriorate so fast. So they have to use so many antibiotics without any, evidence. That's true. But we are sorry, but we don't have choice, because when the patient deteriorates in 24 hours to 48 hours, and when they are in the ICUs and people are having fever, suddenly you see lots of, infiltration in the lungs, then doctor becomes panic also. That's why they have been using. But we have our own national antibiotic policy also. But as Dr. Marcus has mentioned, that we have to have our own guidelines in each and every hospitals. I think Dharan Hospital, the BPKH also, I think they have their own antibiotic.
Yeah, of course. Yeah.
So what we are doing in model also, that every year, with the help of microbiologists, we're getting the microbial patterns, resistant patterns, associative patterns with the antibiotics. With that, we are changing our guidelines also. Okay, I can tell you, like, we have two hospitals, Kathmandu Model Hospitals, and we have Kirtipur Hospital, just about a couple of kilometers far away. But as Dr. Marcus has mentioned, we have lots of born patients in Kirtipur hospitals, and the born patients, they come from all over Nepal, already had so many antibiotics and wound is infected, and there the incidence of Pseudomonas acinetobacter is very high. Though patients are very poor, and we have to use colistin, polymyxin, very expensive antibiotics there. But in our setup, like in Kathmandu Model Hospitals, we used colistin, polymyxin about a couple of years back, when we didn't have this antimicrobial stewardship program. And after that, with all those, hand hygienes and all those, preventive measures, the rate of infections in ICUs, especially ventilated patient, has gone down very drastically. So about 5 years back, 5 years back, we used to have about every, you can say out of 5 patients, 1 or 2 will have Acinetobacter infections. Now in 1 year, we are so proud to say that not more than a couple of infections of Acinetobacter. So we don't have to use those antibiotics. So these things are very important, one thing. And second, like if we develop I mean, doctor, like we have Dr. Sherbadur also, I think they can develop this type of this stewardship program guidelines also. Because of the COVID, in Nepal, we have very few ICUs before, except for Kathmandu and a couple of big cities, very few ICUs. But now, because of the COVID, most of the province and all small district also, we have many ICUs, ventilators, and these facilities are there. So as doctors in those places, consultants, they have been treating those COVID patients more than what we have been treating in Kathmandu, like in Tarai region and other places. They are now so used to, and they are not afraid of ventilators now. All the anesthetists, physicians, they are using this. This is one thing good about the COVID, we can say that. Now, they don't refer patients, they can treat themselves with whenever they need. Lots of ventilators are there. Maybe about, I think, more than 500-600 ventilators within a couple of months we have in Nepal all over. That's very good news. So I think, Dr. Anita, we have described everything very clearly. But last couple of sessions, we have been already talking about this stewardship program. But here, as she has mentioned, first come empirical therapy. For that, you have to know about your local, bacteria, what are the patterns, resuscitability, and all those things. Then we have guidelines like for the pneumonia, community-acquired pneumonia, hospital-acquired pneumonia, mild UTI, complicated UTI, skin infection, intra-abdominal infections. We can have these, most of what antibiotics she have been saying that's what we have been using here also. But after we get the culture report, and then patient becomes slightly better, then we try to de-escalate, as she has told us, from IV to oral medicines, from couple of medicine to just 1 or 2 antibiotics, coming down to 1 antibiotics. And duration also she has mentioned previously, we used to, about 10, 15 years back, most of the time we used to give antibiotic IVs about minimum 7 days, otherwise 14 days or more also. But now it has come down to 5 days or sometimes even 3 to 4 days also. That's good signs. And renal dosing, all those things also she have mentioned very well. So I think that's why there won't be any more questions, not many questions this time, I think. And Dr. Deepak?
Very nice, sir. Congratulations. Thank you.
Thank you, Dr. Joshi. This is Dr. Mackey, Gina Mackey, the other infectious disease fellow at Henry Ford. I think that's really nice summary. I think you kind of hit the points, but I just wanted to reemphasize probably the biggest stewardship activities you can do during COVID would be the duration of antibiotics, making sure, like Dr. Joshi said, to do shorter durations, like 5 days, should still be sufficient because you're still treating a bacterial cap pneumonia instead of extending the duration. And then also just remembering which antibiotics you're using. If someone's coming from the community, they should still be treated as a community-acquired pneumonia, as opposed to someone who's been in the hospital already intubated for some time. So I think just keeping in mind which antibiotics you're using as well as the duration are probably the 2 biggest stewardship activities that can be used during COVID with COVID patients.
Yeah, Dr. Gina. And one thing about the colonizations also, like previous practice in ICU was, whenever patient is ventilated with catheters and IV lines, we used to send samples from catheter side, intubator side, intratracheal tube also, from catheter tubes like that. So now we have routinely stopped all those investigations unless patient is febrile, count is high, and we have a definite, suspicions. Then only we send samples for culture. Although we don't send culture also. So, I think that's better also. Like in burn wound also, if it's open wound, definitely because patient come from village side, poor people, all wound is, you can see there's some infection outside also, there are lots of bacteria. But if it is dry, there is no temperature, the total count is normal, it's no use of sending samples also. That's what we teach our, our doctors, so that it's better not to send samples, culture samples also. If you suspect only, you send it. Yes, doctor.
Yeah.
Yeah.
I think that's a great point. And one point I would make on that is to try to send fresh samples and not from like cultures of the catheters or the devices themselves, because they can be colonized. And so then you might end up picking up colonization instead of a true infection. So thinking of where the culture is coming from is also important.
Can I ask Dr. Gina? We have been, we were taught before, whenever in COPD cases, that patient has a lot of infection. So in our graduate time, then we are told that, okay, you can continue antibiotics in winter time for long durations. Do you practice that now, or you have stopped doing that?
No, we don't. We still only treat the exacerbations and only treat new sputum production, and still only a short 5-day course for COPD. Because otherwise the concern is developing resistance to the antibiotics if you were to extend them for a long duration.
Okay, if you do not have any questions, City General Hospital and the BPKIH, if you want to develop this guideline, and this is the current guideline which are in our website is more, we develop with the Kathmandu Model Hospital and the Kirtipur hospitals. So if you want to develop your own hospital, so we will happy to facilitate the process to develop the stewardship guideline. Maybe Dr. Joshi and Dr. Basuda can help a lot on the technical side.
I can help
so
you.
Please let us know if you want to develop. We'll happy to work together on that part. Thank you. कसैको केही प्रश्नहरू छ? Any questions? City Hospital, BPKIH, Kirtipurबाट कोही पनि आउनु भएन? Any question?
मोडेलबाट आउँदा डाक्टर साहबहरु केही छ कि सोध्नुस्? हुन त अब पुरानै कुरा हो यो सबै हैन? सरकार पठाउने क्या?
If there is no question, Linda, do you have anything to share? Or
no, I'll just, no, I think everything's been covered. These guidelines, again, were developed, with Kathmandu and Kirtipur Hospital.
Yeah.
And they were developed, I guess, in 2018. So, of course, it's something that always has to be reviewed on a regular basis, in terms of looking for susceptibilities. But we wanted to really, I think, a key point is the use of guidelines and how they can help to, decrease unnecessary use of antibiotics in hospital settings. And I'll just also say that we are, this year, we were going to do it last year, but because of COVID, I'm sure many people are also thinking about the use of antibiotics in communities, and we will be developing and implementing some trainings for community-based nurses, midwives, and pharmacists for this year to try and decrease the what is really where many antibiotics are dispensed and prescribed in the communities. So that is something that we'll be doing this year.
Thank you, Linda. So, Dr. Basuda, do you want to say something? Basuda, you are still online?
Yeah, I'm here.
Please.
Most of the things are covered by Dr. Anita and summarized by Dr. Joshi, so not so much things are for me. But anyone who wants to develop the antibiotic susceptibility profile, I can help them if they are interested.
Okay.
Yeah, our Kathmandu Model Hospital is quite interested, like Dr. Deepak, Dr. Sirbadu, or the others also. If you want to think, we're ready to help you. But I think, Dharan, they have yours already. I knew that because I asked Dr. Prahlad Karki a long time back. He said that you have your guidelines also. Every year you have to just check it. Some modified guidelines according to susceptibility and resistant pattern. That is good.
Yeah, I think, every year we should look to update the guidelines. So, I would, very much, like to get, input on that, like as Dr. Deepak mentioned, earlier. So we should put a group together to relook at the to relook at the recommendations.
Thank you, sir.
Have you second shot also? Vaccine?
Well, vaccine is, so, you know, so now there's, so AstraZeneca vaccine is being widely disseminated, and the Moderna is still not widely available, but is, Pfizer is becoming available in, you know, some other countries, and Johnson & Johnson is
Just
going
started.
for approval today. So hopefully that'll be available soon. You know, the Russian vaccine, what I've seen a little bit about that, that's very similar. It's an adenovirus vaccine, similar to the AstraZeneca and to Johnson & Johnson. And you know what I've seen with the Russian vaccine, it, you know, it doesn't go through the same regulatory process, but it is, it actually appears to be a safe and effective vaccine also. But the, I don't know, what do you have available to you in Nepal?
Yeah, we have AstraZeneca.
Yeah.
We have already about 1 million vaccines already here. Now we got another 1 million. Now we have 2 million vaccines now. So by next month, we're having 3 million. So most of the hospital workers and frontline workers, they have already received vaccines. So now our government is trying for the older people, about 70.
That's good. Oh, that's good. Who's doing the immunization? Is it the Ministry of Health, or who's doing it?
Ministry.
Yeah, okay.
It's free, so we don't have to pay anything. That's good. But this AstraZeneca is quite cheap in Nepal because it's India made. It costs about, I think, $3 point something, $3 only. Not expensive at all. So that way we can afford also.
Yeah.
So we are waiting for a second dose. What about
second dose?
yeah, we already crossed four weeks. What is the recommended second dose, sir?
Yeah, there's for AstraZeneca, the vaccine is the 2 doses that are recommended. For the Johnson & Johnson, and when it comes out, it'll be 1 dose. 1 dose is 100% effective in preventing serious infection and hospitalization, and it's about 60 to 70% effective in preventing infection. But but for the AstraZeneca, they're 2 dose recommended now.
Actually, they recommended after 4 weeks, we are supposed to get second dose. But now they have said that they will wait for another 4 weeks. So nearly about, roughly about 6 to 8 weeks afterwards, we are getting second dose. I think that's okay.
Yeah, it can be done a little bit later. Is still that's still okay. Okay.
Yes.
All right.
And I think there will be a talk about vaccines. That date was set, correct? Deepak?
We are planning to
Kilgore.
have a webinar in the March 18.
Okay.
Paul Kilgore will be the give the talk. So March 18 is the same time. That's a water tank. That's a Dr. Joshi. Please.
Today we have very nice talk from Dr. Anita, you know. So about this stewardship program, and within about 30 minutes, she has covered everything. Participants are also Dr. Marcos is here, Dr. Deepak, and then Dr. Sir, he's also here. Dr. Basuda is here, and we have Dr. Linda, and all the doctors from Kathmandu model also. I have to thank them. Everyone has been eager, waiting for this today's topic also. I think by now, most of the doctors and I mean, even the other, nurses and other things also, they have known about this antimicrobial stewardship program. So at least we are doing fine in this aspect. I think we can say that. And I have to thank Mr. Deepak ji also from GTA, for organizing everything.
Okay. Well, thank you, everyone. Thank you, Deepak and Arki and everyone else at
Rajesh,
Neela,
thank you very
everyone
much.
who organizes.
So next webinar is March 18. We are talking about the vaccine, COVID vaccine, and other vaccine also. So see you there. So thank you, everyone.
Thank you.
Bye.
Bye.
Bye. Thank you.
Basuda.
Bye, Basuda.
Bye. Thank you.
Bye.